Thank you, Rajat. Good afternoon, ladies and gentlemen. Uh, at the outset, I am thankful to the organizers for giving me this opportunity. Sorry for the glitch. I think there was some lack of communication between the preview room and the theater. So, I have been asked to speak on the topic of liver transplant in sarcopenia, futility versus utility. Quite the reverse of the topic that Dr. Sehgal has just covered, morbid obesity and liver transplantation. And to begin with, what I'd like to do is to first go over a few definitions. Generally, we tend to use sarcopenia as a short word that also includes the terms malnutrition and frailty along with sarcopenia. These generally go hand in hand but are separate entities, and in the patient, they will need to be tackled simultaneously. So, malnutrition is basically a lack of intake or uptake of nutrition, resulting in altered body composition and body mass, and resulting in diminished function and impaired clinical outcomes. The National Family Health Survey 4 showed that 20% of men in India and almost 22% of women are malnourished. And amongst cirrhotics, this figure may be as high as 30 to nearly 100%. On the other hand, sarcopenia refers to skeletal muscle depletion, which leads to negative effects on both performance and clinical outcomes. And it comprises both depletion of muscle as well as poor strength and poor performance of the muscles. Frailty, on the other hand, is a syndrome of a loss of physiologic reserve, first enunciated in patients in the geriatric age group in the elderly people, which increases vulnerability to various health stressors and including disease, dependence on others, and death. Frailty is a multidimensional construct and also incorporates cognitive, social, and emotional domains. But as far as patients with chronic liver disease, we normally talk about physical frailty as frailty, and as has already been pointed out by many references, sarcopenia and physical frailty are two sides of the same coin and can often be used interchangeably. A quick word about how would you diagnose sarcopenia and frailty in the patient with liver disease. Sarcopenia is basically an index of muscle quantity. So the 1+2 criteria: low muscle mass must be present but must be accompanied by either poor muscle strength or poor physical performance to qualify for the label. Muscle strength is assessed by anthropometric measures, also by bioimpedance and DEXA scans, as well as imaging techniques. And the standard method is the CT3 imaging, CT imaging at the L3 vertebral level for the muscle mass. All the colors that you see are various groups of muscles which are quantified on the CT scan. And according to the European Working Group on sarcopenia and overweight in older patients, cutoff of 50 square centimeters per square meter for men and 39 square centimeters per square meter for women has been recommended as the diagnostic criterion for sarcopenia. I'll come to Indian values in a minute. Now, muscle strength, the usual test one does is hand grip strength. Recently, a knee extension strength is also for the lower limbs has come into practice, while physical performance is assessed by tests like gait speed, 6-minute walk test, chair stand test, and balance test, which together, if they are abnormal, signify physical frailty. Now, myosteatosis, on the other hand, that is excessive fat in the muscle, is an index of muscle quality. Fat in the muscle leads to low attenuation values in the muscle, and generally, like the sarcopenia, it is assessed at the L3 skeletal muscle index level. And basically, these different color codes show you that the total abdominal muscle area can be calculated by measuring normal attenuation values shown in red, that is from +30 to +150 Hounsfield units, while low attenuation muscle values are what is shown in blue, -29 to +29 Hounsfield units, and the yellow shows the values seen with adipose tissue. So using these, it is possible to calculate the ratio between normal and total muscle index and get a myosteatosis index. both poor muscle quality and poor muscle quantity, myostenosis and sarcopenia, result in poor physical performance. So, basically, what we are looking at in our patients is their physical performance, which in earlier stages may well be due to myostenosis, but by and large, in the decompensated patient who comes up for a transplant, is due to myostenosis. So you assess muscle strength by the measuring the dominant hand grip strength, as shown using this device, a hand grip dynamometer in this position. The values, as I told you, for the European groups, and this test has been endorsed by the INASL guidelines also, is up to 27 kilograms. Below that is sarcopenia in men, and below 16 kilograms grip strength is sarcopenia in women, according to the European norms. A variety of frailty assessment tools have been used and standardized. The North American consensus talks about the Karnofsky Performance Score, the Clinical Frailty Score, Activities of Daily Living, and the Liver Frailty Index, which now is generally the most widely used test, as well as the 6-minute walk test. Both in the OPD and the IPD, these can be used. And the INASL recommends using the Liver Frailty Index. If one uses a frailty toolkit in which LFI, KPS, ADL, and the 6-minute walk test are taken, the values can be applied in almost all settings: inpatients, outpatients, ICU, etc. The Liver Frailty Index, which was first described by Jennifer Lai and co-workers in 2017, is basically looks at the grip strength, the chair stand, the number of times a person in 10 seconds can stand and sit up with their hands folded, and the balance test. And an online app is available in which the values can fed in after a mean of 3 values, and you can get the frailty score. For North American population, the index, that is any score above 4.5, has been identified as frail. Some studies have been done in India, and there are Indian recommendations also, because it is clear that ethnic variations, population and gender-specific cutoffs need to be used to define frailty in cirrhosis. And in this study that was done from the MAX group in the liver transplant workers, in a study of about 514 healthy Indians, the values that they found for the L3-SMI and the frailty, the liver frailty index, were significantly different from what had been shown by the European working group, as shown here in blue. And the INASL, in its recent recommendations in 2022-23, has suggested that for Indian populations, the mass should be L3-SMI of 42/38 for men and women. By bioimpedance analysis and DEXA, the appendicular skeletal muscle index, which correlates much better than the L3-SMI with the frailty values, are shown here, as they are shown for hand grip strength, for the liver frailty index, and for the gait speed test. The MAX study found that as many as 60% patients, almost 60% on the liver transplant wait list, were actually frail patients. The other tools and other indices that have been widely used in literature are tests that have not been very well standardized for the Indian populations. Now, why is it so important? What is the clinical significance of frailty, sarcopenia and frailty before and after liver transplant? In a paper that Dr. Punita Tandon and co-workers published, they pointed out that our liver transplant patients are truly geriatric. They are almost 30 years older than their biological age. Almost 40 to 70% of them are sarcopenic, and 18 to 43% are frail. And in a systematic study of 1,107 patients who were waiting liver transplant, the baseline VO2 oxygen consumption was as low as 17.4 milliliters per kilogram per minute, compared to values of 22 to 28 for people who are about 80 years old. So that a 55-year-old liver transplant recipient is probably physiologically aged more like 85 years old. Sarcopenia is also clinically important because it predicts mortality in liver cirrhosis. In this large systematic review and meta-analysis of close to 13,000 patients, sarcopenia, if it was present according to any of the various tools that I've talked about, which was evaluated, was not only very common in prospective recipients to the tune of 44%, but carried a risk of death with a hazard ratio of more than 2. And particularly when the EASL ASLD criteria that I've already talked about, L3-SMI numbers as shown here, were seen, still the risk of mortality in cirrhotics was up to the tune of 1.86%. In the liver transplant recipient also, frailty is very important, and particularly using LFI or other tools, what has been noticed is that 50% of people on liver transplant wait list, as they wait, their liver frailty index scores keeps worsening. A score of more than 4.5, that is, they are identified as frail when they go on the list, results in an increase to the tune of 82% in the mortality in these patients on the wait list. And any number, slight increase also in the LFI, further increases the mortality risk. Post-operative outcomes in frail patients are also much worse, whether it be increased mortality, increased ICU hospital stay, and even 1 year later, their health-related quality of life is poorer than it was before transplant. Sarcopenia has a similar effect on outcomes post-operative in hospital stay, as well as it is an independent risk factor for encephalopathy, infections, and the development of ACLF. In this meta-analysis of over 3,000 patients in 19 studies, as you can see, both waitlist mortality and post-liver transplant survival was significantly impaired to the tune of 84% waitlist and 72% increase in post-liver transplant mortality. So we can clearly see that physical frailty is a major problem in patients subjected to or being subjected to liver transplant. In fact, workers have suggested that incorporating sarcopenia along with MELD can improve the prognostication in patients with cirrhosis as well as those on the wait list. And in this study of about 670 patients, sarcopenia was present in half of them, and it was clear that median survival was shorter in patients who had sarcopenia versus those who did not have sarcopenia. And by incorporating the L3 SMI values and defining the MELD sarcopenia score, the MELD L3 SMI showed an improved prognostication in terms of mortality, overall mortality, and mortality at 1 year. Similarly, when this was assessed in patients who were on the post-transplant wait list in a cohort of about 600 patients, about 43% of whom were sarcopenic, wait list survival was shorter in patients who were on the sarcopenic, and the discriminative performance of the MELD sarcopenia score was better than the MELD score alone in this regard. So this again shows you the clinical importance of incorporating frailty and sarcopenia in assessment in our liver transplant patients. Now, what happens after liver transplant? Sadly, even after liver transplantation, far from improving, there are some data that show that when LFI was calculated 3, 6, and 12 months after liver transplant, in a group of patients whose pre-LT LFI was 3.7, it was actually worse at 3 months, same at 6 months, and only showed marginal improvement, which achieved significance at by 12 months. On the other hand, a larger and a more recent study seems to suggest that cirrhosis-related sarcopenia may not resolve even after liver transplantation, and this group of over 400 patients underwent repeated CT scans. As you can see here, this is the baseline value, and at 1 year, 2 years, and 3 years post-transplant, in men, women, and in the combined group, the sarcopenia values are actually higher. So after liver transplant as well, sarcopenia may not completely recover. And it does affect mortality in this meta-analysis of about close to 8,000 patients. 1, 3, and 5-year mortality in those who underwent liver transplantation with sarcopenia was significantly lower than in patients who did not have sarcopenia. So that brings me to the question that was posed at the beginning. If you have a sarcopenia in a patient who is going to receive and undergo liver transplantation, is it a futile exercise? To summarize what I've told you earlier, sarcopenia is widely prevalent in end-stage liver disease to the tune of almost more than half the patients will be sarcopenic, and a good 35-40% will be frail with poor performance. Sarcopenia increases the perioperative, the wait list, perioperative and postoperative mortality. In fact, 1 year and 3 year and 5 year mortality also in these liver transplant recipients. It can worsen early and may persist for 3 years or longer after liver transplantation. Currently, we do not have validated standard interventions available to improve sarcopenia and frailty even before or after liver transplantation. For lack of time, I have not gone on to the literature and the data on prehabilitation. I think Dr. Pamecha presented a study recently in the NASL in which their first randomized control trial showing benefit in people undergoing prehabilitation in the Indian context was reported. Many such studies are going on. Dr. Punita Tandon spoke about the OPAL study, online physical and rehabilitation study that they're doing in liver transplant recipients in multi-centers in Canada, all of which show promising results. So these studies have yet to be translated into action and clearly and convincingly show benefit, and the various rehabilitation protocols also need to be standardized. So that brings us to the question that does sarcopenia render liver transplant futile? So what is futility in liver transplantation? When is liver transplant futile? This whole thing came up around 2000, about 25 years ago, when the so-called final rule for liver transplantation was declared by the US Department of Health and Human Sciences. And then what was the OPTN network at that time, which said that the sickest patients will have the first priority in the receiving the graft, automatically raising the question then, when is a patient too sick to actually be offered a graft? This has been debated backwards, forwards, round and round for I think over 25 years, but no consensus or agreement has been reached on this, though in practice many people follow the unwritten practice that if a predicted 5-year survival is 50% or higher, only then should a patient be offered liver transplant. But this has not been kind of codified in any consensus statements or in any guidelines. Well, whatever data we have, although again they are not very huge data, but they do suggest that sarcopenia does not meet this futility criterion for liver transplantation. The frailty study that again Jennifer Lai published in Hepatology in 2019 showed that in their group of 1166 patients, 20% of whom were frail before liver transplant, 1 year, 3 year and 5 year survivals numbers are shown here, was similar to what they found in robust patients who did not have frailty at inclusion, although they had a twofold increase in the risk of post-liver transplant death and higher odds of extended hospital stays and greater resource utilization. And that addressing the addressing frailty before liver transplant, particularly in the pre-frail subgroup, can actually improve these results and outcomes, but this has to be demonstrated in real life. The recent INASL consensus on frailty in liver, futility in liver transplant said that sarcopenia and frailty are not criteria for futility, with a moderate level of evidence and a strong recommendation. Although clinical frailty score of more than 7, patients should be individualized because there's at least one published study which shows that their outcome and survival is poorer. Similarly, performance status alone should not be a criterion for futility in liver transplantation as per current data, and the 2024 EASL practice guidelines reinforce the same message that frailty per se should not be a contraindication. Rather, frail people should be evaluated for rehabilitation and nutritional support. So in conclusion, I would say that all prospective recipients should be evaluated for sarcopenia and frailty. Both are very common conditions in cirrhosis. The MELD sarcopenia score that was suggested almost 10 years ago is still not widely validated or in use, but maybe it may have a place if more work can be done on it. Major factor, both of them are major factors that reduce outcomes in liver transplant recipients. However, despite the poor outcomes do not fall below the threshold of futility, only result in an increased resource utilization. So liver transplant cannot be considered futile in patients with sarcopenia. And actually, all of us in the liver transplant community need to work more on prehabilitation programs for patients on liver transplant wait lists, as well as in pre-frail liver cirrhotics, to try and improve them, because at one day or the other, they are all going to be on the transplant wait list. Exercise and nutrition should be structured, made as regular prescriptions, and should all be part of the regular OPD prescription for every liver transplant recipient. Thank you very much for your attention. Happy to take any questions.